Chronic kidney disease, CKD, summary. Chronic kidney disease, CKD, involves long-term damage to the kidneys, often progressing silently until advanced stages. It's crucial for healthcare professionals, especially those in pediatrics, to understand the disease's progression, associated risks, and management strategies to provide comprehensive care and prevent complications. Diagnostic criteria: persistent kidney damage indicated by glomerular filtration rate, GFR, 60 milliliters per min, 1.73 meters squared, or markers of kidney damage for 3 months. Key markers include proteinuria, albumin to creatinine ratio 30 milligrams per gram, structural abnormalities on imaging, and electrolyte imbalances due to tubulo-interstitial damage. Etiology: primary causes, diabetes mellitus, hypertension, and glomerulonephritis are leading causes. Secondary causes include polycystic kidney disease and repeated episodes of acute kidney injury, AKI. Pathophysiology: progressive loss of nephrons, leads to compensatory hyperfiltration in remaining nephrons, eventually resulting in sclerosis and further nephron loss. Metabolic complications, such as hyperkalemia, metabolic acidosis, and disturbances in calcium phosphate metabolism. Clinical features, often asymptomatic in early stages. Later stages may present with fluid overload, hypertension, edema, uremia, fatigue, nausea, pruritus, neurological disturbances, mineral bone disorder, bone pain, fractures. Diagnostics: serum creatinine and BUN elevated levels indicate reduced kidney function. Estimated GFR, eGFR, calculated from serum creatinine, age, sex, and race. Urine analysis: proteinuria, presence of casts. Imaging: ultrasound for structural abnormalities. Management: 1. Address underlying causes, control diabetes and hypertension. 2. Medications: RAS inhibitors, ACE inhibitors, e.g. lisinopril, or ARBs, e.g. losartan, for blood pressure control and nephroprotection. Diuretics for volume overload. Erythropoiesis-stimulating agents for anemia. Phosphate binders to manage hyperphosphatemia. Vitamin D analogs for bone health. 3 dietary adjustments: sodium and protein restriction, potassium and phosphorus management based on stages. 4 renal replacement therapy. Dialysis or kidney transplantation in end-stage renal disease, ESRD. Monitoring: regular follow-up to monitor kidney function, electrolyte levels, blood pressure, and treatment effectiveness. Screen for cardiovascular disease, the leading cause of mortality in CKD. High yield points for specialists. Early detection through routine screening in at-risk populations is crucial due to the asymptomatic nature of early-stage CKD. Management focuses on slowing disease progression, controlling blood pressure, and preventing complications. Multidisciplinary approach involving dietitians, nephrologists, and cardiologists is essential for comprehensive care. Pediatric patients require additional considerations for growth, development, and long-term kidney function preservation. Clinical case: pediatric chronic kidney disease, CKD. Patient information: age, 8 years, sex, female. Medical history: diagnosed with type 1 diabetes mellitus at age 5. Family history of hypertension. Presenting complaint: the patient presents with persistent fatigue, decreased appetite, and a recent onset of nocturnal enuresis. The mother reports that the patient has been less active and appears pale. Clinical examination: vitals: BP 1/3 by 85 milligrams elevated for age, HR 88 BPM, RR 16 breaths min. Physical exam: mild periorbital edema, pallor, no overt fluid overload, and normal heart and lung examination. Investigations: laboratory tests: serum creatinine 1.2 milligrams per elevated for age, eGFR 55 milliliter min, 1.73 metaquameters, urinalysis 2+ proteinuria, no hematuria, HbA1c 8.5%, hemoglobin 10.2 grams per liter, serum electrolytes: potassium 5.2 millimolar, calcium 8.9 milligram, phosphate 5.5 milligrams. Renal ultrasound: bilateral renal echogenicity increased, consistent with chronic parenchymal changes. Differential diagnosis: CKD secondary to diabetic nephropathy, acute kidney injury superimposed on CKD, glomerulonephritis. Diagnosis: CKD stage 3 secondary to diabetic nephropathy, considering the patient's history of diabetes, persistent proteinuria, and reduced eGFR. Management plan: 1. Optimize diabetes control, intensify insulin therapy with close glucose monitoring to achieve an HbA1c target as close to normal as safely possible. 2. Blood pressure management, Initiate an ACE inhibitor, e.g., lisinopril, for BP control and nephroprotection, with careful monitoring for hyperkalemia and renal function. 3. Nutritional management, consultation with a pediatric nutritionist for dietary recommendations to manage protein intake and control phosphorus and potassium levels. 4. Anemia management, consideration of erythropoiesis stimulating agents if anemia worsens with careful monitoring of hemoglobin levels. 5. Renal bone disease, monitor for signs of CKD mineral and bone disorder and manage with vitamin D supplementation if necessary. 6. Multidisciplinary approach, regular follow-ups with a pediatric nephrologist, endocrinologist, and dietitian. Education for the patient and family about disease progression, treatment goals, and lifestyle modifications. Discussion points: the importance of strict glycemic control in delaying the progression of diabetic nephropathy, the role of RAS inhibitors in slowing CKD progression and their potential side effects, dietary modifications essential for managing CKD, focusing on protein, net potassium, and phosphorus intake, monitoring for complications of CKD, including hypertension, anemia, and mineral bone disorders. Follow-up: 3-month follow-up with repeat labs, eGFR, electrolytes, HbA1c, blood pressure assessment, and evaluation of growth parameters. Adjust treatments based on lab results, blood pressure control, and any new symptoms.